Hello everyone, I am Dr. Nishant Verma, interventional cardiologist practicing in Delhi and Bahadurgarh. Today I'll be speaking on the topic how to manage very high risk diabetic patient. Our patient is a 54-year-old female with type 2 diabetes since last 4 years, and she has come for a routine checkup where she is complaining of generalized weakness. She has a history of hospitalization for ACS 1 year back, and she underwent PTCA. She has a positive family history also. Her father had an MI and he underwent CABG 5 years ago. The patient is obese with a BMI of 29.7, body weight 71 kgs. Blood pressure is on the higher side, 146 by 86. HbA1c is not well controlled, is 8.4%. LDL cholesterol is 75, which is on the higher side for a cardiac patient. eGFR is 65, slightly reduced, with urine is showing presence of microalbuminuria. 2D echo is showing mildly dilated left and right atria. LV ejection is normal. Presently, she is on the following medication: metformin 1 gram PD, glimepiride 4 mg OD, losartan 50 mg OD, atorvastatin 40 mg OD, amlodipine 5 mg OD, clothianidone 15 mg per day, and metoprolol XR 50 mg daily, and aspirin 75 mg daily. So we need to increase her anti-diabetic medication because currently she is only on metformin and glimepiride, and still her HbA1c is not well controlled. Also, for cardiac patients, those having history of a cardiovascular event, glimepiride is not a very good drug to use, so we should add other agents. Patient has sedentary lifestyle and she is trying to avoid weight gain, exercises a few times a week, but she is not able to control her weight, and now she is reporting occasional hypoglycemia events as well. So we need to replace her glimepiride with other anti-diabetics which can reduce her cardiovascular and renal. So what are the important challenges in this patient? First of all, there is uncontrolled hyperglycemia. Second is obesity. Third is uncontrolled blood pressure. Fourth, that she is cardiac patient. She has a history of previous MI. And fifth is renal dysfunction in the form of microalbuminuria. So what is the risk status of this patient? She is at a very high risk because she is a relatively younger diabetic with end organ target damage and prior acute vascular event, and also because her HbA1c is not well controlled, and there is weight gain as well. So, as we all know, type 2 diabetes is a complex disease characterized by chronic hyperglycemia, which gradually increases over time. And type 2 diabetes is associated with other cardiovascular risk factors like abdominal obesity, arterial hypertension, dyslipidemia, thrombogenic status, low-grade inflammation, and oxidative stress. These risk factors accelerate atherothrombosis, which results in cardiovascular disease like coronary heart disease, stroke, and cerebral arterial disease. And studies have shown that almost two-thirds of patients with type 2 diabetes will die from cardiovascular disease, and almost half from coronary artery. In the last 2 decades, a better management for diabetic patients has allowed reducing the incidence of cardiovascular complications. But yet, the residual risk remains high in patients with diabetes. CKD and heart failure are important complications which are of major interest, also because of the reduction in premature death among type 2 diabetes patients. ADA in 2019 has recommended that a CV protective agent should be added first on to OHAs in case of early CVD in patients with type 2 diabetes. In 2015, the EMPIRIC study was published, which opened up a new chapter in management of diabetic patients. This study demonstrated significant benefits of SGLT2 inhibitors, which is empagliflozin, in reducing the risk of heart failure by 35%. And among participants with a baseline history of heart failure, empagliflozin was associated with a numerically lower rate of heart failure hospitalization and cardiovascular death. And among patients who had an initial heart failure hospitalization, empagliflozin was associated with a near twofold reduction in the risk of a subsequent cardiovascular death or heart failure hospitalization. So it was concluded that SGLT2 inhibitors prevent the development of heart failure in diabetic patients. And positive top-line results of Emperor Reduce has been recently published in patients with heart failure and reduced ejection fraction. And in this trial, even non-diabetic patients also benefit from empagliflozin in terms of heart failure prevention. The EMPA-Heart CardioLink 6 study has demonstrated that empagliflozin could also produce early reverse cardiac remodeling in type 2 diabetes and stable coronary artery disease. Also, in a sub-analysis from EMPIRIC study, empagliflozin was shown to decrease new onset or worsening of nephropathy by 39% on top of RAS blocker therapy. And the addition of empagliflozin was associated with slower progression of kidney disease. So, cardiovascular and renal benefits seem to be maintained independent of eGFR levels, even with progressive eGFR decline. Because of the unique mechanism of action of SGLT2 inhibitors, they have a range of effects that may translate to potential benefits beyond glycemic control, especially in diabetes and nephropathy patients. Associated pleiotropic effects like reduction in blood glucose concentration, natriuresis, and decrease in BP and body weight changes might confer protective effects on the kidney by reducing CV and risk factors in diabetic patients. Another important anti-diabetic agent class of agents is DPP-4 inhibitors, of which linagliptin has a unique profile with primarily non-renal but hepatobiliary route of elimination, requiring no dose adjustment in patients with CKD. And Carmelina study, which is the linagliptin CV outcome study, has confirmed that linagliptin reduces the progression of gonorrhea by 14%. The reduction in the risk of genital infections associated with SGLT2 inhibitors has also been reported when a DPP-4 inhibitor is added, and that can be because of a better glucose control, although other possible mechanisms might also exist. So, to conclude, in a very high risk patient who has uncontrolled diabetes with renal dysfunction and cardiovascular disease, it is very important that target HbA1c should be maintained, and we should prevent cardiovascular events, we should prevent heart failure, and we should prevent progression of renal dysfunction. And for this, it is important that in addition to metformin, if still the hyperglycemia is not controlled, we must add SGLT2 inhibitors like empagliflozin with or without combination of linagliptin. And this will help in reducing the further cardiovascular and renal